Welcome everybody to this edition of Attention Talk Video. I'm your host, Attention Coach Jeff Copper. I'm here today with Dr. Charles Parker from Norfolk, Virginia. Dr. Parker, welcome to the show.
Hey, thanks for having me, Jeff. I appreciate it.
Hey, we've had you on a couple times before, and I've always enjoyed interviewing you on the video show, also the radio. And we did a couple shows a while ago talking about the paying attention to the meds that help you pay attention, and we alluded to in one of them that we were going to come back and do a show on drug interaction, which is really what today's is about. And we're being very precise in this particular situation, but as I understand it, and correct me if I'm wrong, when you take stimulant medications, we've talked about they have to go through the body in order to get through the brain. And one of the things that we've talked about a little bit is the meds go through the liver, and there's this pathway, I think you call it 2D6. Am I accurate in saying that's a big deal? Can you talk about that a little bit and what its function is, and then we can talk about how it can affect the ability of stimulants to get to where they're supposed to go?
Well, 2D6 is the abbreviation, yes, and it's really the formal long name is cytochrome P450 2D6. And what that pathway is, it's a liver pipeline. And in that liver pipeline, it comes in different sizes. So you can have a real narrow pipeline, and you can have a big fat 2D6 pipeline. And when you have a fat pipeline, the medications that come up through it very quickly, and you need a larger dose to have an effect psychologically to actually change the mind. Mm-hmm. Whereas when you have a little bitty pipeline like this, what happens is they get backed up, and if you use a big dose, you're going to overdose the person, and they're going to feel blown out the top. They're going to have side effects.
Now this 2D6 pipeline, when I hear pipeline, I mean literally I think of a pipe, a tunnel or something like that.
Yeah.
And which would seem to indicate that it can be measured. What is this just a metaphor, or can it be measured?
No, there are many companies out there that measure pipeline sizes and variations. It's a genetic measurement. They're genetic measurement companies. We do it in our office frequently. And we, if a person's having a problem, first of all, we're intuitively on top of it. I've been on top of this for many years. I learned it back in the 1990s. I mean, it's a long time ago. But the bottom line is, once you learn it and you see it, it makes you more conservative in the way you use medications. So you can be flip about diagnosis and this and that and the other thing, but the actual practical application of using the medication has to be extremely conservative in honor of the size variations of that genetic 2D6 pipeline.
So would it be fair to say that stimulant medications, the 2D6 pipeline goes through the liver, and is it fair to say it's actually kind of a funnel so that the stimulants have to go through this pipeline, whether big or small, and to be processed in order to get to the brain in the proper place, the right time?
Yes, Jeff. To be precise now, I want to clarify one important point. Amphetamines pass through the 2D6 pipeline. Methylphenidate products block the 2D6 pipeline. So it's a good reason to not use a methylphenidate product like a Ritalin or Ritalin LA or Concerta or whatever with an amphetamine product, because it will sit right on the top of that pipeline so that the amphetamine can't come through. And so if you use a methylphenidate with a amphetamine, you'll be in a problem. And that's where we're getting around to ultimately, was the antidepressants that also affect the blockage of that 2D6 pipeline, so things can't come up through it.
But here's the trick, if I understand this correctly, is that, as you've described to me, is if you have this pipeline and the stimulants are supposed to be kind of going up, and you're taking some of the depressant medications, which we'll talk about in a second, it can block that pipeline, but it doesn't like it's blocked it right now. It's something that it kind of slows it down and accumulates over a period of time. So in other words, there's a delay when you start taking this between maybe the impact of this might manifest.
That's the key point. In fact, that's the reason people aren't paying attention to it, because it doesn't occur acutely. So if you have this mix, now it would occur acutely if the person's been on 40 milligrams of Prozac, some high dose of Prozac, and it's like, oh, they have ADD. Let me give them an amphetamine product. Well, Prozac blocks that pipeline like no other drug does. Prozac and Paxil are significant blockers of that 2D6 pipeline. So if a person's on Prozac and you give them an amphetamine product, Well, that pipeline's already blocked. You can't give them an amphetamine product. In a week or two, they're going to be out the roof with an amphetamine. They're going to be, because it's going to accumulate, they're going to be angry, irritable, touchy, sensitive, and they'll say, oh my gosh, that amphetamine caused the problem. No, the Prozac caused the problem because it's blocking the pipeline. And the same thing happens now. Back to your point, though. This is the deal with the long term. If you have a lower dose of Prozac or add the Prozac on, it may take a while for that amphetamine to accumulate. It can take 2-3 months. And then the person starts having a big aberrant reaction. They're all over the place, hyper. It looks like the medicine isn't working again because their brain's running all over the place. It's because the backup has occurred and they need to be off the antidepressant, specifically the Prozac or the Paxil, because it's causing the amphetamine to accumulate and they're actually coming out the top of the therapeutic window, which is what I have done several videos about over on over at my channel on YouTube over there.
So for the people out there that listen, what I'm hearing, Dr. Parker, is if you're taking the stimulant medications and these other things, it basically you have this pipeline and it impacts that pipeline, and what happens is it's not immediate and it can accumulate over a period of time, and the symptoms of this blockage might manifest 2-3 months down the road. And the problem with it is the cause and effect. When did this start happening and when does the impact start? And people are looking at it as two completely separate events, not knowing that they're related.
They don't know they're related. And I've had colleagues of mine, medical colleagues, who know about this interaction, go around nationally and lecture that it's okay to use Prozac with Adderall because then you can lower the dose of the Adderall because the Prozac is going to cause it to back up. So they know about the backup. They're recommending to medical professionals that they use the interaction to lower the dose of Adderall. That is completely, read my lips, absurd. And everybody that knows anything about drug interactions totally agrees with me on this. This isn't me. You can't make this stuff up. You can make up the recommendation that you use them that way. I mean, in a way, it makes sense, but it's absolutely incorrect. And my colleagues who understand drug interactions completely agree with me on this.
So it's interesting that you bring up one of the purposes here, and I need to make this actually clear. This is a Attention Talk video, and I'm an attention coach, and I'm not here to give any kind of medical advice. I'm just interviewing Dr. Parker to help bring awareness to you to understand some of the things that might be going on and look for the signs so that you then can go back and talk to your mental health professional if something's going on. So the more education that you have, the more empowered you are to go back and have a conversation because, maybe they missed something. I mean, people are human, but I think this is real powerful stuff because, as we've talked about before, medications for ADHD, it's not like you just take 2 aspirin and call me in the morning. It's about getting the right dose and the right timing in the right place. And this is one of those things that can impact that. And as you as a consumer probably should need to know just for the knowledge. Dr. Parker, is there anything in this kind of space that we have, we've talked about depressant medications. Now, all depressant medications don't impact 2D6, right?
Well, they don't. Let me mention one quick thing real quickly because I'm with you on this. I can't give medical advice either. What I'm doing is attempting to educate the public. And if their doctor needs to see a book in this regard, here's Drug Interaction Principles for Medical Practice. This happens to be an older edition, 2nd edition. Koza, Armstrong, and Osterheld. That is a significant volume that details exactly what I'm talking about without any question. Now, the medications that don't interact with the antidepressant medications that don't interact with amphetamines, for example, and by the way, Prozac and Paxil also interact with methylphenidate in another way, which I won't bother you with right now, but Prozac and Paxil, as far as I'm concerned, if you've got ADHD, need to be off the radar. They are not clean. They actually cause these 2D6 problems. Now, what are the antidepressants that you can use? I'm not working for a pharmaceutical company, by the way. I have in the past. I've lectured to my colleagues since 1996 nationally on these very issues, but I'm not proposing any medications. I'm telling you how they work. And what happens is Effexor, venlafaxine, Prozac, Prestique, they both begin with a P. Prestique, those three are serotonin, norepinephrine reuptake inhibitors. They don't block 2D6. Lexapro and Celexa don't block 2D6. Zoloft doesn't block 2D6. Now, it's really interesting to me, doing a lot of work as I do with the ADD community. Nationally, people say, well, in my computer, it says that there's a reaction between venlafaxine or Effexor and amphetamines. I'm here to tell you that the book, if you look at the book that I just showed you, it's not in there. We don't have a problem with it. I don't know where that information came from, but there is some misinformation out there about interactions that aren't really occurring and are not a problem.
Well, just for our listeners out there, this is an awful lot of information, and I'm trying to kind of simplify it down. It seems to me that if you're taking stimulant medications and you're taking other medications, if we simple this down to the most common form, if an individual went back to their mental health professional and said, here's the medications that I'm taking, do any of them go through or impact 2D6? Would that be like the one question or the one thing to say that would be a really good filter to determine if any drugs that you're taking might have an impact on stimulant?
It would, but I can tell you a lot of the medical community completely disagree with me on this point. They don't accept it because it's not an acute thing. So, I mean, there are many, many ADHD experts in the country that repeatedly give Prozac with amphetamines. So they argue that it's not a problem because they don't see it acutely. Now, they'll see it down the road and make the change, but what that brings in is the metaphor of chasing your tail in the woods, running around trying to get the medication adjusted. Even ADHD experts disagree with me on this point, even though it's in the book. So the point is 2D6, they say, well, it doesn't make any difference. I mean, you can bring 2D6 up. I'm saying that you would prefer, if you're going to say something to your doc, take a look at the literature. You can look it up on the internet. Just put in Prozac, 2D6, and amphetamine. Just put that in on the internet and see what's out there. And there are numerous references, including the package insert itself for Prozac, that say that this interaction occurs. And if it occurs, why would you do that to yourself? If you're being treated, you just say, I just prefer not to use Prozac. It's not a problem.
Got it.
And I just prefer not to use Paxil. I don't want to use those. I understand there's a potential reaction there. And they may say, well, there's not a reaction. It's like, please, let's do something else.
So what I'm hearing is for you listeners out there, if you're interested in meds and you're taking other meds and you can ask and find out if any of the other medications you're taking have any impact on 2D6, at that point in time, you know what medication is there, and you can do your own research with your medical health professional to determine really what makes a lot of sense to you. If they're working fine, that's one thing, but just this can be real confusing and complicated, but I think if you focus in on that, find out if you are taking another drug that has an impact, you're then empowered to have some conversations and research to really kind of find out more.
I think this is where you really do a tremendous service to the community, Jeff, by having these kind of discussions, because the informed citizenry is going to change the way medicine is practiced. I mean, people can argue this all day, but the people are the people that are having the reaction. And that's the bottom line.
And it's one of the things I like to do is try to boil this down. But it's interesting to me because I'll be honest with you, when I think about being a physician in a practice, managing the people and have them coming through, it's enough to deal with the everyday stuff and the business, but also to keep current on all the medicine that's all the research that's changing and kind of coming through. To me, honestly, I wouldn't want the job to be overwhelming because I don't know how you can keep current and keep track of it all. Particularly me, I have a hard time remembering words, much less methylphenidate and blah, blah, blah. So, again, I appreciate you coming on our show, Dr. Parker, because it's these types of things that we can talk about, the complexity of it, and then try to boil it down in layman's terms so that the average person can kind of reclaim control of understanding what's going on with them to try to get the right med at the right dose at the right time.
That's the deal, Jeff. Thank you very much. I appreciate you having me.
For those of our viewers that want to learn more about you and the book, where's the best place to go?
Well, I have a book out called New ADHD Medication Rules, and Jeff, I hope you do put it in the description down below on the YouTube video, but it's at the website, ADHD Medication Rules.
Okay.
It's the new version, so it's new ADHD, but the URL is ADHD Medication Rules, and it's also, you can find it at CorePsych, which is my treatment site, CorePsych.com.
All right. Dr. Parker, thanks again for coming on Attention Talk Video. As always, it's been a thrill to have you on.
Thank you, buddy. Have a great day.
Take care, everybody. Attention Talk Video, its owners and hosts are not consultants, lawyers, doctors, mental health professionals, counselors, or therapists, among others. We do not give advice. Further, we do not represent as fact the views, opinions, or advice of our guests. We are in the business of asking questions. Our sole purpose is to stimulate your brain to pay attention to things differently, to discover new ways or solutions that move you forward. If you're interested in the content of this show, you should seek the advice of a qualified professional.